A 67-year-old male presents with a swollen, warm, and minimally painful foot. I am showing you the radiograph of the foot. Describe the findings.
Okay, looking at the images, the radiograph of the foot demonstrates marked joint destruction, fragmentation of articular surfaces, and subluxation at the midtarsal joint. There is dense subchondral sclerosis and extensive periarticular debris or loose bodies within the space, along with severe structural deformity. Additionally, there is prominent, track-like, vascular calcification of the arterial tree. The combination of dense bones, joint destruction, debris, dislocation, and deformity in a swollen foot represents a neuropathic arthropathy or Charcot joint. The presence of arterial calcification strongly suggests diabetes mellitus as the underlying cause.
What is the differential diagnosis for neuropathic arthropathy, and how does the anatomical location guide us to the primary etiology?
The differential diagnosis for a neuropathic joint depends on its location. For the ankle and foot, the most common causes in adults are diabetes mellitus and chronic alcoholism, while myelomeningocele and congenital insensitivity to pain predominate in children. For the upper limb, particularly the elbow and shoulder, syringomyelia is the classic cause. For the spine and larger lower extremity joints like the hip and knee, tabes dorsalis due to neurosyphilis is the primary etiology. Repetitive microtrauma in a sensory deficient limb is the common pathway for all these causes.
I'm showing you comparison radiographs of neuropathic joints from other patients. Describe the findings.
The first comparison radiograph shows another diabetic Charcot foot, demonstrating marked sclerosis, fragmentation, and subluxation at the midtarsal joint, along with severe destruction and dislocation of the metatarsophalangeal joint. The second comparison radiograph demonstrates a Charcot elbow in a patient with syringomyelia. It shows advanced articular destruction, dense subchondral sclerosis, and florid loose body debris within the elbow joint. Both cases highlight the classic 6 Ds of neuropathic joints: distension, density, destruction, debris, dislocation, and disorganization.
Discuss the clinical presentation and why bone mineralization is characteristically preserved or increased in a Charcot joint.
In that case, clinically, patients typically present with a swollen, warm, and erythematous joint that mimics cellulitis or osteomyelitis, but with normal inflammatory markers. Despite the advanced joint destruction, they often report minimal pain due to loss of pain sensation and proprioception. Because patients continue to weight bear on the insensitive limb, there is a lack of the juxta-articular osteopenia that typically accompanies inflammatory arthritis. Instead, the bones remain densely sclerotic. An exception occurs if there is a superadded bacterial infection or osteomyelitis, which will cause localized osteopenia and progressive bone erosion.
How would you manage this patient as a radiologist?
Well, as a radiologist, I would recommend comparing these radiographs with any prior foot films to assess the rate of joint disorganization. I would recommend a dedicated MRI of the foot with intravenous contrast, or a combined labeled white blood cell and sulfur colloid bone scan to distinguish active Charcot neuroarthropathy from superadded osteomyelitis. I would communicate these findings to the referring clinician to guide foot offloading and orthotic support. Finally, I would suggest referral to endocrinology for glycemic control and a specialized diabetic foot clinic.